1, 2,
And review, female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, start of
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
You know, the human heart really gets like all the glory, doesn't it?
Absolutely.
Like we write poems about it, we sing songs about it. When you watch any medical drama on TV, the climax is always that's, you know, the flatlining monitor.
Right, the frantic chest compressions.
Exactly. The dramatic shock from the defibrillator.
Yeah.
The heart is just treated as this ultimate symbol of life.
It's the star of the show.
But when you actually spend time in a critical care unit, you start to realize something pretty profound. The heart, for all its fame, is, I mean, it's essentially just a mechanical pump.
It really is. It's a muscle that squeezes. It's relatively simple, honestly.
Right. So if you want to find the true, quiet, microscopic intelligence of the human body, you know, the organ system that is actually making thousands of calculated life or death decisions every single minute.
You have to look lower. You
Yeah.
have to look at the kidneys. And it's funny you mentioned the heart getting all the glory because, well, if the kidneys fail, that heart will eventually stop beating. It is an absolute non-negotiable physiological certainty. The kidneys are like the silent architects of human homeostasis.
So welcome to the deep dive. You, our listener, are stepping into the room with us today for a very specific high-stakes exploration.
We are so glad you're here with us.
Our mission today is to completely rewire how you look at the human urinary system. We are putting on our elite ICU intensivist hats.
We are stepping right into the shoes of a critical care nursing instructor today.
Exactly. And we are aggressively applying the Pareto principle, the 80-20 rule, to the kidneys, the ureters, the bladder, and the urethra.
Which means, you know, we aren't going to sit here and recite textbook anatomy just for the sake of it.
No, nobody has time for that.
Right. We are ruthlessly extracting only the high-yield information. We are hunting for that 20% of clinical knowledge that drives 80% of bedside decision-making.
The stuff that actually saves lives.
Exactly. We are looking for the subtle, almost invisible clues of physiological deterioration that happen like hours before that cardiac monitor ever even alarms.
I love that. And I want to set the stakes right out of the gate here. Why do we need this level of intensity for the urinary system?
Because the general public, and honestly, even some novice clinicians, they operate under this massive misconception.
Yeah.
They think the kidneys are just like passive urine factories, you know, a waste disposal chute.
Right, like a biological trash can.
Exactly. But that couldn't be further from the truth. The kidneys are the ultimate hemodynamic and homeostatic regulators of the entire human body.
Okay, let's unpack this.
Yeah, so if a person experiences total renal failure and we don't intervene with dialysis, I mean, death is inevitable. They manage the exact volume and chemical composition of your extracellular fluid.
The exact volume.
Right. But beyond just waste excretion, they dictate your systemic blood pressure minute by minute. They manufacture the hormone that signals your bone marrow to produce red blood cells.
Yep.
They activate vitamin D so your bones don't literally shatter. They meticulously balance the acid in your blood. Basically, if the kidneys go down, every single other organ system is on a ticking clock until total collapse.
Okay, that is a fantastic framework to start with. So our journey today is going to trace the path of a single drop of blood from the moment it enters the renal artery to the eventual creation and excretion of urine.
It's quite a trip.
It is. But we are just taking a tour. We are acting as bedside detectives here. At every anatomical stop, we are looking for the exact moment the physiology fails, you know, how that failure shows up in the patient right in front of us, and most importantly, the priority actions we have to take to save them.
And to spot the abnormal, you have to have a really deep instinctual respect for the normal.
Right. What does good look like?
Exactly. We have to start with the macrostructure. The kidneys are paired, bean-shaped organs, but their location is actually a huge clinical clue. They are retroperitoneal. That means they sit behind the peritoneal cavity, tucked right against the back muscles on either side of your vertebral column. So roughly about the level of the 12th thoracic vertebra, T12, down to the 3rd lumbar vertebra, L3.
Okay, which means they're relatively exposed from the back, right? Because they aren't massive. Each one only weighs like 4 to 6 ounces.
Yeah, around the weight of a smartphone.
That's tiny. And they're about 5 inches long. Oh, and the right one sits just a little bit lower to make room for the liver, right?
You got it. But even though they are vulnerable back there, they have this brilliant anatomical defense system. Each kidney is encased in this dense, thick layer of perirenal fat and connective tissue.
So it's like bubble wrap.
Essentially, yeah, it literally suspends them and cushions them. And shrink-wrapped tightly over the actual organ tissue is a smooth, fibrous membrane called the renal capsule.
Oh, I've heard of that.
Yeah, this capsule is basically a biological shock absorber. So if a patient is in a car accident or takes a physical strike to the mid-back, that capsule absorbs the blunt force trauma to prevent the delicate internal tissue from instantly rupturing.
But as fascinating as that shock absorption is, the thing that immediately jumps out of the source material, the thing that an intensivist cares about more than anything else, is the blood supply.
Oh, the blood flow is staggering. It completely defies logic when you look at the size of the organ.
Right.
These two organs, weighing a combined 10 or so ounces, receive roughly 1,200 milliliters of blood every single minute.
Over a liter a minute, just for these two little smartphone-sized organs.
Yeah, that is 20 to 25% of your total cardiac output. A quarter of every single heartbeat goes straight to the kidneys via the renal arteries, which branch directly off the massive abdominal aorta.
Okay, I was trying to visualize this.
Yeah.
Imagine a city where a quarter of the entire electrical grid is dedicated to powering like one single water filtration plant.
Okay, I like this.
Right. If that filtration plant shuts down, the city's water supply becomes toxic. But conversely, if the city's power grid experiences even a slight brownout, that filtration plant is the very first thing to trip its breakers and go offline.
That is a perfect way to look at it.
So if the kidneys take a quarter of our cardiac output, are they basically the canary in the coal mine for a systemic cardiovascular collapse?
That analogy is spot on, and this is the core of hemodynamic critical care. Because the kidneys demand such a massive percentage of blood volume to function, they are exquisitely sensitive to drops in systemic perfusion.
Okay, trace that for me. What does that actually look like in a patient at the bedside?
So imagine a patient who has a severe gastrointestinal bleed, or maybe they are in cardiogenic shock after a massive heart attack.
Okay.
The trigger is decreased cardiac output. The heart isn't pumping enough blood, or there simply isn't enough blood in the pipes because they're bleeding out. The immediate physiologic change is that the body panics. The sympathetic nervous system kicks in and says, uh-oh, we have to protect the brain and the heart at all costs.
It prioritizes the vitals.
Exactly. So it severely vasoconstricts the blood vessels going to the kidneys, shunting that blood away. The kidneys experience an immediate, profound loss of perfusion.
They are starved of oxygen and pressure.
Precisely. And the clinical finding you will see at the bedside, often hours before the blood pressure completely bottoms out, is a sudden, sharp drop in urine output.
So you see in the Foley bag first.
Yes. The urine turns dark, it gets really concentrated, and then it just stops. The kidneys shut down the factory because they don't have the raw materials, the blood pressure, to run the machines.
That brings up a really crucial concept from the clinical notes regarding age, which is called renal reserve.
Oh, this is a huge one. It's a vital exam concept and an absolute reality of bedside nursing. You have to account for gerontologic changes.
Meaning changes as we age.
Right. Starting right around age 30, the kidneys begin to gradually lose about 10% of their size, their weight, and their vascular blood flow with every passing decade.
Wait, 10% every decade?
Yeah. The actual number of functioning filtering units decreases over time.
So a 30-year-old patient who suffers a trauma and loses a liter of blood might have enough functional reserve in their kidneys to compensate.
Exactly. They clamp down, they hold on to water, they ride out the storm until we can give them IV fluids or blood.
But take an 85-year-old patient. They might have lost 50% of their original renal reserve just through, normal aging and mild atherosclerosis.
Yes, and under normal, calm conditions, they maintain homeostasis perfectly fine. They feel fine.
But introduce a stressor like a bout of severe diarrhea, or a mild hemorrhage, or a systemic infection, and they have absolutely zero backup capacity.
They just fall right off the cliff. The warning sign that the patient is getting worse is seeing an older adult with what looks like a relatively minor fluid loss or a slight drop in blood pressure who suddenly stops producing urine entirely.
Because they have no buffer.
Exactly. You cannot wait on that. You have to realize their aging kidneys are decompensating rapidly and they are heading straight into acute kidney injury.
Okay, so we've established the macro blood flow. To understand how that injury actually happens, we need to zoom all the way in. We are moving from the macro to the microscopic filter where the blood is actually processed, the nephron.
Yes, the nephron is the functional working unit of the kidney. You have roughly 1 million of these microscopic marvels packed into each kidney.
1 million in each.
Yeah. The outer meat of the kidney tissue, the cortex, and the inner pyramid-shaped structures, the medulla, are just packed with these nephrons. And they all eventually drain their finished product urine into the renal pelvis.
Which is like a funnel, right?
Right. It's a funnel that can only hold a tiny amount, maybe 3 to 5 milliliters, before it forces the urine down the ureter and into the bladder.
But the magic happens inside the nephron itself. And it is a highly complex machine with distinct compartments.
Very distinct.
It starts with the glomerulus, which is this tight, spherical tuft of up to 50 microscopic capillaries, all encased in a structure called the Bowman capsule.
Right.
And after the glomerulus, you have a winding plumbing system, the proximal convoluted tubule, the descending and ascending loop of Henle, the distal convoluted tubule, and finally the collecting duct.
To think like an intensivist, you have to understand the physics of urine formation. It is a 4-step process: filtration, reabsorption, secretion, and excretion.
Okay, 4 steps.
And the entire cascade begins at that capillary tuft, the glomerulus.
The blood arrives there under really high pressure.
Very high pressure.
Wow.
The blood vessel bringing blood into the glomerulus, the afferent arteriole, is actually wider than the vessel carrying blood out, the efferent arteriole.
So a big pipe going in, small pipe coming out.
Exactly.
Okay.
This creates a massive bottleneck. It builds up incredible hydrostatic pressure inside those capillaries.
Oh, that makes sense.
And that physical pressure physically forces a portion of the blood plasma across a semipermeable membrane and right into the Bowman capsule.
And the rate at which this happens is the glomerular filtration rate, the GFR. Basically the holy grail number of kidney function. The source material states a normal GFR is 125 milliliters per minute.
Let's focus on that semipermeable membrane for a second, because this is where the pathophysiology happens. Under normal, healthy conditions, this membrane is porous, kind of like a microscopic coffee filter.
Right.
It easily lets water, electrolytes, and small metabolic waste products like urea and creatinine slip right through. But the pores are physically too small to allow large items to pass.
Large items meaning red blood cells, white blood cells, platelets, and large plasma proteins like albumin.
Exactly. So the fluid that gets squeezed through the glomerular filtrate looks almost exactly like blood plasma, just stripped of all the cells and large proteins.
Okay, so trace the pathology for me. Trigger, physiologic change, clinical finding. What happens when that filter breaks?
Okay, the trigger is an insult to the kidney, perhaps glomerulonephritis from an autoimmune response, or, very commonly, long-term uncontrolled diabetes, where the high blood sugar literally glycosylates and damages the delicate blood vessels over years.
So the sugar basically caramelizes the filter.
That's a really grim but highly accurate way to picture it, actually. The physiologic change is that the microscopic pores in the glomerular capillary membrane become damaged and widened.
The holes get bigger.
Yes, the permeability skyrockets. The filter just has gaping holes in it.
Which means the large items that were supposed to stay in the blood start falling through the coffee filter into the urine.
Yes. The clinical finding you will immediately detect on a urinalysis is proteinuria. Massive amounts of protein in the urine and hematuria, intact red blood cells in the urine.
And I want to connect the dot here because this is where that intensivist thinking really comes in. If a patient is pouring protein out into their urine, they're losing albumin from their blood. And albumin is the molecule that acts like a sponge in your blood vessels, holding water inside the vascular space through oncotic pressure.
You've hit the exact mechanism of a massive clinical complication right there.
So if you pee out all your albumin, you lose that oncotic pressure. The water in your blood vessels no longer has anything holding it there, so it just leaks out into the surrounding tissues.
It bird spaces.
The patient swells up like a balloon with generalized edema. It's a direct cascade starting from a microscopic hole in the glomerulus.
That is exactly how you have to trace the pathology. Now, let's look at the sheer scale of this operation. We established that the normal GFR is roughly 125 milliliters per minute.
Right.
That means your glomeruli are pushing 125 milliliters of fluid into the tubular system every 60 seconds.
But we definitely don't pee out 125 milliliters a minute. That would be, what, hundreds of liters a day? You would be dead from dehydration in an hour.
Which brings us to the tubular system. Of that 125 milliliters filtered every minute, the vast majority is immediately reabsorbed by a network of capillaries surrounding the tubules.
It gets pulled right back into the blood.
Exactly. In fact, only about 1 milliliter per minute actually makes it all the way to the end to be excreted as urine.
Wait, you filter 125, but you only pee out 1. The efficiency there is just staggering.
It is a masterpiece of biological engineering, and each section of the tubule has a specific job. In the very first section, the proximal convoluted tubule, about 80% of the water and electrolytes are immediately grabbed back into the blood.
Right off the bat.
Yep. Furthermore, under normal conditions, 100% of all glucose and amino acids are reabsorbed here. None should make it to the urine. 0.
I want to pause on the glucose because this explains a massive symptom of a very common disease. You just said 100% of glucose is reabsorbed. But in a diabetic patient whose blood sugar is totally out of control, say their blood glucose is 400 or 500, what happens?
Well, the proximal tubule is like a factory line, and it only has so many workers' transporter proteins to carry glucose back into the blood.
It's limited.
Right. When the blood sugar is that high, the amount of glucose filtering through simply overwhelms the workers. It hits what we call the renal threshold.
The tubule maxes out.
Exactly. The tubule maxes out, and the excess glucose just stays in the tubular fluid and travels down the line.
And glucose is an osmotically active particle. It pulls water toward it, right?
Yes, exactly. The excess glucose acts as an osmotic diuretic inside the nephron. It physically traps water in the tubule, preventing it from being reabsorbed back into the blood.
So the patient starts producing massive amounts of urine. They get polyuria.
Yes, that is the exact cellular mechanism for why uncontrolled diabetics urinate constantly, feel incredibly thirsty, and become profoundly dehydrated.
Yeah, it's the kind of aha moment we
Yeah.
are looking for. Okay, so after the proximal tubule, the fluid dips down into the lipid of Henle, which is primarily responsible for creating a massive concentration gradient.
Right.
It uses this intricate countercurrent multiplier system, where the descending limb lets water out, and the ascending limb actively pumps out sodium and chloride. Basically, it makes the deep tissue of the kidney extremely salty.
And that salty tissue is absolutely essential for the final stage of regulation, which occurs in the distal convoluted tubule and the collecting duct. This is the hormonal command center.
The boss.
Right. This is where the fine-tuning of your blood volume and blood pressure really happens.
Let's introduce the VIP hormones then.
The first major player is antidiuretic hormone, ADH, which is produced in the hypothalamus and released by the posterior pituitary gland in the brain.
Okay, let's weave a patient into this to make it real.
Good idea.
Let's introduce a case study that we can follow. Meet AK, a 28-year-old amateur athlete. He is currently halfway through a grueling summer marathon. He has been sweating profusely for 2 hours. He is severely hypovolemic and dehydrated.
Okay, let's put on our critical care hats and trace AK's physiology. The trigger here is profound dehydration. Because AK is sweating out water, his blood plasma is becoming thicker. The concentration of sodium in his blood is actively rising.
It's too concentrated.
Right. The physiologic change starts in his brain. Specialized sensors called osmoreceptors in his anterior hypothalamus detect this thick hyperosmolar blood.
The brain realizes there's a fluid crisis.
Yes. The hypothalamus sends an emergency signal to the posterior pituitary to just dump antidiuretic hormone, ADH, into the bloodstream.
Antidiuretic, literally against urination.
Exactly. The ADH travels to AK's kidneys and binds to receptors on the distal convoluted tubules and the collecting ducts. Normally, these ducts are relatively impermeable to water.
Like a field pipe.
Right. But ADH forces them to open up microscopic water channels called aquaporins.
And because the loop of Henle made the surrounding kidney tissue incredibly salty, the moment those water channels open, the water is sucked violently out of the urine and pulled back into AK's bloodstream.
Yes. The compensation is achieved, the blood volume is defended, and the clinical finding. If AK were to stop and try to pee, he would produce a tiny, tiny volume of extremely dark, highly concentrated urine.
Because the kidneys are squeezing every last drop of moisture back into his body.
Exactly.
Beside ADH, There's aldosterone, which comes from the adrenal cortex, sitting right on top of the kidneys.
The adrenals.
Aldosterone also acts on that distal tubule, but instead of just opening water channels, it commands the tubule to aggressively reabsorb sodium. And wherever sodium goes, water naturally follows.
But there is a catch with aldosterone. It operates on an exchange program.
A trade-off.
Yeah. To take a positively charged sodium ion from the urine back into the blood, it has to kick out a different positively charged ion into the urine.
Oh, I see.
It trades sodium for potassium. So high aldosterone means you retain sodium and water, but you waste potassium.
That is a huge clinical pearl. And we can't forget the counter-regulatory hormone, atrial natriuretic peptide, or ANP.
Right. ANP is the emergency pressure release valve. It is secreted by myocyte cells in a right atrium of the heart itself.
The heart talking to the kidneys.
Exactly. If a patient is fluid overloaded, say, from congestive heart failure, the sheer volume of blood stretches the walls of the right atrium. The trigger is atrial stretch. The heart releases ANP.
And ANP travels to the kidneys and essentially screams, "Stop holding on to water."
Yes. It inhibits ADH, it inhibits the reabsorption of sodium, and it forces the kidneys to dump a large volume of dilute urine to get rid of the dangerous fluid overload.
So we have all these beautiful, elegant mechanisms concentrating and diluting the urine based on exactly what the body needs at that second. What is the subtle clinical clue that tells a nurse this entire tubular system is just dead?
It's a metric called specific gravity, which you get from a standard urinalysis. Specific gravity measures the density or the concentration of particles in the urine.
Normal is roughly 1.005 to 1.030, right? It fluctuates. So AK, the marathon runner, would have a high specific gravity, close to 1.030, because his urine is so concentrated.
Yeah.
But if I drink a gallon of water right now, mine would drop down to like 1.005.
Exactly. It should constantly fluctuate based on your hydration. The danger sign, the subtle deterioration clue, is a specific gravity that becomes fixed at roughly 1.010.
Fixed, meaning it never goes up and it never goes down no matter what you do to the patient's fluid status.
If it is fixed at 1.010, it is a catastrophic finding because 1.010 is the exact specific gravity of normal blood plasma.
Oh, wow.
It means the filtrate is entering the tubule, washing completely through the system, and exiting as urine without a single alteration. The tubule has completely lost its ability to concentrate or dilute.
Is paralyzed.
Yes. This is isothenuria, and it is a hallmark late-stage sign of end-stage renal disease.
That is chilling. The fluid goes in and the exact same fluid comes out. The intelligence is gone.
The factory is completely abandoned.
Wow. We've spent a lot of time on fluid dynamics, but earlier you mentioned the kidneys moonlighting as an endocrine gland. Let's dig into the secret hormones, because this connects to some of the most dangerous complications we see in critical care.
Right. The kidneys are a massive endocrine organ. They secrete erythropoietin, renin, active vitamin D, and prostaglandins. Let's start with erythropoietin.
Okay, so erythropoietin stimulates the bone marrow to produce red blood cells. But why the kidney? Why does an organ that makes urine control red blood cells?
Think back to the blood flow we talked about. The kidneys receive 25% of the cardiac output.
Right.
They sample a quarter of your entire blood volume every minute. That makes them the perfect sensor for oxygen levels in the body. The trigger is hypoxia, or a decrease in renal blood flow.
So if the kidneys sense that the oxygen tension in the blood is too low,
the physiologic change is that they immediately synthesize and release erythropoietin.
and then the hormone travels to the long bones, stimulates the marrow, and the compensation is an influx of fresh red blood cells to carry more oxygen.
Exactly. But apply the intensivist mindset here. What happens in chronic kidney failure?
The tissue is dead.
Right. The renal tissue is scarred and necrotic. The oxygen sensors are dead. The trigger happens. They are hypoxic. But the factory is closed. Zero erythropoietin is produced.
So the clinical finding is profound. Chronic anemia.
Yes.
The patient is constantly fatigued, pale, and short of breath, not because they are actively bleeding somewhere, but because their bone marrow never gets the email to make more blood.
Precisely. It's a supply chain failure. Next is renin. This is the big one. This is the absolute cornerstone of blood pressure management.
Renin.
Renin is synthesized and stored in specialized cells called juxtaglomerular cells, which literally wrap around the afferent arteriole right before it enters the glomerulus.
So they are sitting right on the inlet pipe, feeling the pressure of the blood coming in.
Yes. They are baroreceptors. They feel physical pressure. If systemic blood pressure drops from hemorrhage, dehydration, or heart failure, the pressure inside that inlet pipe drops.
And they feel that drop.
They do. The juxtaglomerular cells sense the loss of stretch. They also respond to a drop in sodium delivery to the macula densa cells in the tubule. When they sense this crisis, they dump renin into the bloodstream.
And renin is the first domino in a massive chain reaction.
The renin-angiotensin-aldosterone system, or RAAS, this is complex, but it is the key to understanding a dozen ICU medications.
Okay, let's break it down.
Renin enters the blood and hunts down a large inactive protein produced by the liver called angiotensinogen. Renin cleaves it, turning it into angiotensin I.
But angiotensin is weak. It doesn't do much on its own, right?
Right, it's just an intermediate. It floats through the venous system until it hits the massive capillary beds of the lungs. The lungs are lined with an enzyme called angiotensin-converting enzyme, or ACE.
ATE. Just like the ACE inhibitor drugs we give for high blood pressure.
Exactly. ACE grabs angiotensin I and converts it into angiotensin II. And angiotensin II is a monster.
A monster in what way?
It is one of the most potent vasoconstrictors in the human body. It immediately clamps down the peripheral arterial system, artificially jacking up the systemic blood pressure to keep the brain and heart perfused.
So it forces the pressure up by shrinking the pipes.
Yes, it also goes to the adrenal glands and triggers the release of aldosterone, which, as we discussed, hoards sodium and water, further expanding the blood volume. It's a brutal, highly effective survival mechanism.
But wait, I want to push back on this, or at least point out what seems like a massive design flaw here.
Okay, what is it?
If angiotensin II is causing this profound systemic vasoconstriction, clamping down all the arteries, wouldn't it clamp down the renal arteries too? Wouldn't the kidneys essentially strangle their own blood supply to death while trying to save the rest of the body?
That is brilliant, and you've just uncovered why the kidneys have a local defense shield.
A shield?
Yes. To prevent angiotensin II from causing complete renal ischemia, the inner tissue of the kidney, the renal medulla, constantly synthesizes prostaglandins, specifically prostaglandin E2 and I2.
And prostaglandins do what in this context?
They are local vasodilators. They act directly on the renal arterioles, forcing them to stay open. They directly counteract the extreme vasoconstriction of angiotensin II and sympathetic norepinephrine. The prostaglandins ensure that even while the rest of the body is clamped down tight, renal blood flow is maintained. They are the kidney's personal life raft.
Okay, this just blew my mind because I'm thinking about pharmacology now. When someone twists their ankle or has a headache, what do they take? They take an NSAID, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, indomethacin.
And what is the mechanism of action of an NSAID?
It blocks the cyclooxygenase enzyme. It stops the body from producing prostaglandins to reduce pain and inflammation. But wait, by blocking prostaglandins systemically, you are stripping away the kidney's life raft.
Bingo. You are ripping away the shield. If you have a healthy 20-year-old taking some ibuprofen, they have enough reserve to handle it. But take an elderly patient in the ICU with heart failure. Their cardiac output is terrible. Their RAAS system is working in overdrive, pumping out tons of angiotensin II to keep their blood pressure up.
Right.
Their kidneys are surviving solely because those local prostaglandins are forcing the renal vessels open against all that pressure.
And if the nurse gives that patient a dose of an NSAID for, like, the fever?
You shut down the prostaglandin production. The angiotensin II goes completely unopposed. The renal arteries violently clamp shut, and the patient goes into acute, catastrophic renal failure within hours.
Just from an NSAID?
Yes. That is why NSAIDs are on the absolute hit list of nephrotoxic medications in the critical care unit. You have to be so careful.
That is the ultimate why behind the what. That is incredible. We also have to touch on vitamin D. I used an analogy earlier that the kidney is like a building's thermostat and furnace, but it also manages the structural integrity of the building through calcium and bone health.
Right. The vitamin D pathway is a huge exam trap and a tragic clinical issue for dialysis patients. We get inactive vitamin D from our diet, or our skin makes it when exposed to sunlight.
Right, the sunshine vitamin.
The liver does a first pass at activating it, turning it into calcidiol. But it is still inactive. The second, final, and most crucial step of activation happens exclusively in the kidneys. The kidneys turn it into calcitriol, the active form.
And why do we care about active vitamin D?
Because without it, your gastrointestinal tract is practically waterproof to calcium. You could drink a gallon of milk, and without active vitamin D, that calcium will just pass straight through your gut and into the toilet.
Really?
Yeah, you will absorb almost none of it into your bloodstream.
So applying the intensivist mindset again, the patient's kidneys fail, the factory dies, no more active vitamin D is produced.
The GI tract stops absorbing calcium. The calcium levels in the blood plummet. Hypocalcemia.
And the body hates hypocalcemia. Calcium is required for muscles to contract, for the heart to beat. The body will panic.
It absolutely panics. The parathyroid glands, those 4 tiny glands sitting on your thyroid in your neck, sense the drop in calcium. They secrete parathyroid hormone, PTH.
And PTH does what?
PTH has one brutal mandate: restore blood calcium levels by any means necessary. So it goes to the largest calcium bank in the body, the skeleton.
Oh, no.
It activates osteoclasts, which literally dissolve the bone matrix, pulling calcium out of the bones and dumping it into the blood.
At the exact same time, the failing kidneys lose their ability to excrete phosphorus.
Yes.
Yes.
So phosphorus levels in the blood skyrocket.
And then what?
Phosphorus binds to the free calcium, creating calcifications in the blood vessels and driving the functional calcium levels even lower, which makes the parathyroid pull even more calcium from the bones.
It's a vicious cycle. And the clinical result is a condition called renal osteodystrophy. The patient's bones become hollow, brittle, and just incredibly fragile. You see ESRD patients in the ICU who suffer spontaneous femur fractures just from being rolled over in bed by nursing staff. It's devastating.
It really is. It's a tragic cascade. So we have mapped the physiology and the failure points. Now, let's step up to the bedside. How does the critical care nurse spot this breakdown during a physical assessment?
Right. We have to rely heavily on pattern recognition here. We know normal urine output is roughly 1,500 milliliters a day. The volume at night is usually less than half of what is formed during the day because naturally, ADH levels increase while we sleep, so we don't have to wake up.
But if a patient starts reporting nocturia, waking up multiple times a night to urinate, that is a subtle red flag.
Why?
It could mean the aging kidneys are losing their ability to concentrate urine at night, or it could point to undiagnosed heart failure, where the fluid accumulated in the legs during the day is finally mobilized back to the kidneys when the patient lies flat.
Looking at the physical exam, the skin tells a massive story too. We look for pallor, which connects directly back to the lack of erythropoietin and the resulting anemia we talked about. But the source material also mentions a yellow-gray cast to the skin and excoriations from severe scratching.
Yeah, when the kidneys stop filtering, metabolic waste products, urea, creatinine, uremic toxins build up in the blood. They eventually start precipitating out into the skin.
Ew.
This causes profound intractable itching, known as pruritus. In severe end-stage uremia, the urea can actually crystallize on the surface of the skin like a white powder, which is called uremic frost.
Uremic frost, that sounds awful. We're also looking for edema, right? Periorbital edema, swelling around the eyes, is often a classic early sign of fluid retention, especially in protein-losing kidney diseases, before it becomes massive peripheral edema in the legs.
Correct. And we must assess for pain. The kidneys are retroperitoneal, so you don't typically feel them from the front of the abdomen. The critical nursing maneuver is percussing the costovertebral angle, the CVA.
This is the anatomical angle on a person's back, formed by the bottom edge of the rib cage, the 12th rib, and the vertebral column.
Exactly. You place one hand flat over the CVA, and you strike the back of that hand with the ulnar edge of your other fist. A firm thump. Normally, a person just feels the pressure of the thump. But if CVA tenderness is present, if the patient jumps off the table in agony, it is a massive diagnostic clue. It indicates severe inflammation of the kidney capsule,
which points toward an acute kidney infection like pyelonephritis, maybe a massive cyst in polycystic kidney disease, or an obstructing kidney stone causing the capsule to stretch from backed up urine.
We also have to categorize urine output abnormalities. This is an elite ICU skill, rapidly differentiating between polyuria, oliguria, and anuria, and understanding the cellular why behind each.
Let's do it. We discussed polyuria earlier, a highly increased volume of urine. If you see polyuria, you should immediately think of diabetes mellitus, where the glucose is dragging water out via osmotic diuresis, or diabetes insipidus, which is a brain issue where there's a complete lack of ADH, or obviously the administration of pharmaceutical diuretics.
Next is oliguria. This is defined as a severe decrease in urine, specifically 100 to 400 milliliters in a 24-hour period.
Okay, 100 to 400.
If you see oliguria, think of our canary in the coal mine analogy. Think of a pre-renal state. Severe dehydration, hypovolemic shock, cardiogenic shock, or a massive transfusion reaction where the damaged red blood cells are clogging the microscopic filters.
And finally, anuria, the absolute red alert. Technically, this means no urination, but practically it's defined as less than 100 milliliters in 24 hours.
If you see anuria, the system is dead or blocked. Think acute kidney injury that has progressed to total failure, end-stage renal disease requiring immediate dialysis, or a complete bilateral ureteral obstruction where urine simply cannot physically exit the body.
I want to bring our marathon runner, AK, back into the picture now. Let's move him from the race course to the emergency department.
Okay, lay out his presentation for me.
So AK is brought to the ED in acute distress. He is experiencing severe colicky pain in his left flank that comes in excruciating waves. He is nauseous and vomiting. He finally provides a urine sample, and it's a dark, smoky tea color. Vital signs. Blood pressure is 150/670, heart rate is a 108, respiratory rate 22. The nurse thumbs his back, and he has profound, positive left CVA tenderness.
This is where we apply the intensivist framework. As a nurse, you are assessing the entire picture, not just individual vital signs. The assessment reveals profound dehydration from the marathon. We have localized the issue to the left upper urinary tract because of the left CVA tenderness. And we have that dark, smoky urine.
Which the textbook tells us is a classic presentation of hematuria blood in the urine.
But wait, we have to look deeper. Is it blood or is it something else? AK just ran 26 miles. He has massive acute muscle breakdown. When skeletal muscle is crushed or pushed beyond its limits, it dies and releases a protein called myoglobin into the blood.
This is rhabdomyolysis.
Yes, and myoglobin is a massive molecule.
It is huge.
Right. It travels to the kidneys, gets filtered at the glomerulus, and it is physically too large to smoothly pass through the tubules. It crystallizes. It creates physical logjams inside the nephrons, causing acute tubular necrosis.
Oh, wow.
And when myoglobin is excreted, it turns the urine a dark, smoky, reddish-brown color that looks exactly like old blood.
So our differential diagnosis, the highest priority nursing problem, is twofold here. Either AK has acute renal colic from a kidney stone that was precipitated by his dehydration, or R, he has acute rhabdomyolysis and myoglobin is literally suffocating his nephrons.
What is the priority nursing action? You have to distinguish if this is an upper tract kidney issue or a lower tract bladder issue. We felt the CVA pain, which points high.
Right.
If the issue is simply urinary retention, say an enlarged prostate clamping the urethra, the bladder would be massively full. You would percuss the lower abdomen, the suprapubic area, and it would sound dull, like thumping a water balloon.
Yeah.
You would palpate a hard, distended mass. AK doesn't have that. The problem is in the kidney.
So we have a kidney crisis. How does the nurse escalate this? What is the difference between notifying the provider, calling a rapid response, or preparing for a code?
The severe CVA pain, the tachycardia of 108, the smoky urine, these warrant an urgent provider notification. You need IV fluids to flush the myoglobin, you need pain control, and you need a CT scan to look for stones. However, the situation changes instantly if you observe specific deterioration clues.
The patient is getting worse if...
The patient is getting worse if AK suddenly develops anuria, urine output drops to absolute zero, coupled with sudden confusion or cognitive changes, pointing to uremia. Or, most critically, if you are watching the cardiac monitor and you suddenly see peaked T waves or a widening QRS complex.
Cardiac dysrhythmias.
Yes. If you see anuria and cardiac dysrhythmias, that is a code or rapid response situation. Because the kidneys excrete the vast majority of the body's potassium. If the kidneys are blocked by myoglobin, potassium levels spike immediately in the blood.
Explain the physiology there. Why is potassium so lethal?
Potassium dictates the resting membrane potential of the heart muscle cells. It controls how easily the heart can fire an electrical impulse. When potassium levels in the blood get too high, the electrical gradient is destroyed.
The heart just loses its rhythm.
The heart muscle becomes incredibly irritable, then sluggish, and finally it just stops. Hyperkalemia will cause lethal ventricular fibrillation or a systole faster than almost any other electrolyte imbalance.
To confirm what we suspect from the physical exam, we have to look at the numbers. Let's pivot to diagnostics, high-yield labs, and the exam traps you need to avoid.
The foundational test is the urinalysis. We are looking at the specific gravity, checking for protein, red blood cells, and white blood cells. But the true microscopic clue we are hunting for are casts.
I see casts on lab reports all the time, but it sounds so abstract. It sounds like something you put on a broken leg. What is a cast in the urine?
Think of casts as literal physical molds of the inner plumbing of the kidney. The ascending loop of Henle constantly secretes a sticky mucoprotein called TAM horsefall protein. Under normal conditions, it just washes away. Okay.
But when the tubule environment becomes highly concentrated, stagnant, or highly acidic-like, when a patient is severely dehydrated or in acute kidney injury, that protein gels. It solidifies.
And as it solidifies, it traps whatever debris is floating in the tubule with it.
Exactly. If there is bleeding in the kidney, red blood cells get trapped in the gel. If there is an infection, white blood cells get trapped. The gel hardens into a microscopic cylinder that takes the exact physical shape of the tubule. Eventually, the pressure builds up and blows this solid cylindrical plug out into the urine.
It's literal debris from a failing system.
Yes. If you see casts under the microscope, it proves that there is active inflammation, stagnation, or destruction occurring deep inside the nephron's microscopic plumbing. For AK, with his rhabdomyolysis, you would likely see muddy brown granular casts, the classic signature of acute tubular necrosis caused by myoglobin.
Next, we have to talk about the gold standards for evaluating kidney function: BUN, serum creatinine, and creatinine clearance. The source material emphasizes creatinine clearance as the holy grail. Why is that? We have to understand what creatinine is. It is a waste product of normal muscle breakdown. Because muscle mass remains relatively constant day to day, creatinine is released into the blood at a very steady, constant rate.
Right.
Crucially, it is almost entirely filtered by the glomerulus and excreted in the urine with almost zero reabsorption.
So if we measure exactly how much creatinine is in the blood and compare it to exactly how much creatinine ends up in the urine over a specific time period, we can calculate precisely how many milliliters of blood the glomeruli are clearing every minute. We can mathematically calculate the glomerular filtration rate.
But the collection process is fraught with nursing errors. It is not a simple blood draw. To calculate creatinine clearance, you need a meticulous 24-hour urine collection, A&D, a serum blood draw during that same 24-hour window.
Walk me through the priority nursing action for that collection, because one mistake ruins the entire diagnostic.
The nurse must instruct the patient to void and then throw that first urine specimen completely away. You flush it. That marks the start of the 24-hour clock.
So the bladder is empty to start.
Exactly. From that exact second forward, every single drop of urine must be saved in a specialized, often ice container. If the patient accidentally flushes a single void at 2:00 a.m., the entire test is invalid, and you have to start a new 24-hour clock.
Then there is the BUN to creatinine ratio. This is one of the most elegant pieces of physiological deduction in the ICU.
Oh, I love this one.
Normal BUN, blood urea nitrogen, is roughly 10 to 20. Normal creatinine is roughly 0.6 to 1.2. So the normal ratio is usually between 12.1 and 20.1.
Here is the intensivist trick. Both BUN and creatinine are waste products, and both will rise when the kidneys fail. If a patient's BUN is 40 and their creatinine is 4.0, the ratio is 10.1. They are both elevated equally.
Right, they move together.
That tells you the problem is intrinsic. The kidney tissue itself is dead or dying.
But what if the ratio is elevated? What if the BUN is 60, but the creatinine is only 1.5? The ratio is 40.1. The BUN is skyrocketing while the creatinine barely moves.
That points to a pre-renal problem. It means the kidney tissue is actually fine, but the blood flow to the kidneys is terrible.
What's the cellular mechanism behind that? Why does BUN rise faster than creatinine in low-flow states?
Urea is a small molecule. In the proximal tubule, urea is passively reabsorbed back into the blood along with water. Creatinine is not.
Okay.
If a patient is severely dehydrated or in heart failure, the blood flow to the kidney is slow. The filtrate moves very slowly through the tubules. The body frantically reabsorbs as much water as possible, and because the flow is so sluggish, a massive amount of urea gets dragged back into the blood with the water.
So the BUN skyrockets because of the slow flow, but the creatinine continues to be excreted normally.
Exactly. An elevated BUN to creatinine ratio screams dehydration, low cardiac output, or a massive GI bleed where digested blood proteins are converted into urea by the liver.
We have to touch on the electrolyte traps again. We mentioned potassium earlier. Normal is 3.5 to 5.0 middle EQL.
Potassium is the first electrolyte to become abnormal in kidney disease because the kidneys are solely responsible for excreting the excess from our diet. A potassium level greater than 6.0 is a critical, immediate threat to life.
A code level threat.
Yes. If you get a lab value showing a K of 6.5, your priority nursing action is not to chart it and wait for rounds. It is immediate pharmacological intervention.
You push IV calcium gluconate to stabilize the heart muscle, then IV insulin dextrose to force the potassium temporarily out of the blood and hide it inside the cells, buying you time to set up dialysis.
Exactly. What about exam traps related to diagnostics and prep? There are major pitfalls here.
Let's talk about bowel preps. Many radiologic studies, like looking at the retroperitoneal kidneys, require clearing the bowel so stool doesn't block the X-ray.
And the trap is what you use to clear it. Do not, under any circumstances, give magnesium citrate or saline laxative enemas like Fleets to a patient in kidney failure.
Because they can't clear the magnesium.
The failing kidneys cannot excrete the massive magnesium load. The patient will develop acute magnesium toxicity, which causes profound muscle weakness, suppresses the central nervous system, and leads directly to respiratory depression and cardiac arrest.
Another trap is the urinalysis and culture.
Urine culture contamination is incredibly common. The bladder itself is a sterile environment. But the urethra, the tube leading out, is colonized with normal flora bacteria.
Right.
If you just hand a patient a cup and tell them to pee into it, the very first wash of urine sweeps all that urethral bacteria straight into the sample. The lab will grow out a bacterial count of greater than 10 to the 5th organisms per milliliter, giving a false positive for a urinary tract infection.
And the patient gets put on unnecessary antibiotics, risking resistance and C. diff. So the priority nursing action is to ensure a clean catch midstream specimen.
Yes.
You instruct the patient to clean the periurethral area, start voiding into the toilet to flush out the urethral flora, and then catch the sample midstream.
Those tiny nursing details completely alter the diagnostic pathway of the patient.
Speaking of things we put into the patient, we need to carefully examine radiologic procedures, endoscopies, and the specific medications that can absolutely destroy the kidneys. Let's look at interventions.
We will start with a high-stakes vascular procedure, the renal arteriogram or angiogram. This is used to visualize the complex renal blood vessels, often to diagnose renal artery stenosis, which causes severe hypertension, or to map the vasculature before a transplant. A large catheter is inserted into the femoral artery in the groin, threaded backward up the abdominal aorta to the renal arteries, and iodine contrast media is forcefully injected.
The word artery is the red flag there. This is a high-pressure system. What is the priority nursing action post-procedure?
The immediate life-threatening complication is not in the kidney, it is at the puncture site. You are worried about massive arterial hemorrhage from the femoral artery or an arterial thrombus forming on the catheter and blocking blood flow to the leg.
So the nursing actions are: first, place a firm pressure dressing over the groin injection site. Next, mandate strict, flat bed rest for hours. The affected leg must remain completely straight. If they bend their hip, they can pop the clot. Then you must assess the peripheral pulses, the pedal pulse in the foot, every 30 to 60 minutes.
The patient is getting worse if you check the pulse in that foot and it is suddenly absent, or if the foot becomes cold, pale, and numb. That means a clot has formed, cutting off perfusion. You are looking at potential limb loss. You notify the provider immediately. Alternatively, if the patient complains of sudden, severe lower back pain, you have to suspect a retroperitoneal bleed.
Sneaky bleeding.
The artery is leaking backward into the abdominal cavity, where it can hide liters of blood before you see a drop in blood pressure.
Another procedure is cystoscopy. This is a urologic endoscopy. The urologist inserts a lighted scope directly up through the urethra into the bladder to look for tumors, remove stones, or take biopsies.
It is highly invasive and traumatizes the mucosal lining. The nursing care revolves around teaching the patient what to expect. Post-procedure, burning on urination, pink-tinged urine, and urinary frequency are expected. The tissue is angry and inflamed.
But there is a line between expected trauma and catastrophic complication.
Yes. If you see bright red bleeding or thick blood clots after a cystoscopy, that is not normal. It indicates a severe hemorrhage or that the scope actually perforated the bladder wall. Think bladder rupture. Notify the provider immediately, monitor for signs of peritonitis or shock, and prepare for fluid resuscitation.
Let's run down the hit list of nephrotoxic medications. These are drugs that, while curing one problem, can silently murder the nephrons.
We already covered NSAIDs and how they block the protective prostaglandins. Next on the list are antimicrobials, specifically the aminoglycosides like gentamicin and tobramycin, as well as vancomycin. These drugs accumulate in the cells of the proximal tubule and cause direct cellular toxicity. We also have ACE inhibitors like captopril.
Wait, ACE inhibitors? I thought ACE inhibitors were protective for the kidneys, especially in diabetics.
They are in the long term because they lower the systemic blood pressure that batters the glomerulus. But remember how they work? They block angiotensin II. Angiotensin II normally constricts the efferent arteriole, the exit pipe of the glomerulus, which maintains the high pressure inside the filter. If you block that, the exit pipe dilates. The pressure inside the glomerulus plummets.
The GFR drops.
Exactly. In a patient who already has marginal blood flow, starting an ACE inhibitor can cause an acute severe drop in GFR, throwing them into acute kidney injury. It requires intense monitoring of their serum creatinine when initiated.
And finally, the big one, contrast media. Contrast-induced nephropathy, or CIN. This is a massive issue in the hospital. We scan everyone. CT scans, angiograms, IVPs, they all use iodine-based contrast dye.
CIN occurs when that thick iodine-based contrast is given to a patient who is already hypovolemic, elderly, or has compromised renal function. The contrast is hyperosmolar. It causes massive, direct oxidative stress and vasoconstriction in the renal medulla. It poisons the tubule.
The trigger is the contrast injection. The physiologic change is acute tubular necrosis and ischemia. The clinical finding. Over the next 48 to 72 hours, the patient experiences an acute drop in urine output and a sharp spike in their serum creatinine.
The priority nursing action for CIN is aggressive prevention. The absolutely most important treatment is administering massive intravenous hydration, usually normal saline before, during, and after the procedure. You have to physically flush the toxic contrast through the tubular system as fast as possible so it doesn't have time to sit and burn the tissue. We may also administer N-acetylcysteine, a medication that acts as a renal vasodilator and a potent antioxidant, scavenging the free radicals caused by the dye.
We have covered immense ground today. We have mapped the macroanatomy and the microscopic physics. We have tracked the hormones, decoded the labs, and navigated the procedural traps. It is time for the handover. We are going to aggressively synthesize this using the 80-20 rule.
This is the intensivist debrief. If you are about to walk into an ICU shift and you remember only 5 things from this entire physiological deep dive to keep a patient alive, here they are.
Number 1, core pathophysiology.
The kidneys are hemodynamic regulators that demand 20 to 25% of the total cardiac output, roughly 1,200 millibellar a minute. They filter 125 millibellars a minute at the glomerulus, but reabsorb 99% of it to maintain exact fluid, electrolyte, and blood pressure homeostasis. Their microscopic efficiency is the only thing standing between the patient and cardiovascular collapse.
Number 2, key assessment finding.
Anuria less than 100 millioils of urine in 24 hours, or a urinalysis showing a fixed specific gravity of exactly 1.0101. Either of these findings means the filtering and concentrating systems of the nephron have catastrophically failed. The organ is dead.
Number 3, most dangerous complication.
Hyperkalemia, a serum potassium level greater than 6.0 MEQL. Because the kidneys are responsible for excreting potassium, renal failure leads to immediate accumulation, destroying the resting membrane potential of the heart and causing fatal ventricular dysrhythmias.
Number 4, priority nursing action.
Aggressively hydrate patients receiving IV contrast dye to flush it through the system. Vigilantly monitor the BUN creatinine ratio when administering nephrotoxic drugs like vancomycin or NSAIDs. And crucially, always hold magnesium-based bowel preps in patients with renal failure to prevent fatal central nervous system and respiratory depression.
Number 5, most important treatment.
Post-vascular procedure care. For a renal arteriogram, mandate strict bed rest, keep the affected leg completely straight, and perform frequent peripheral pulse checks to prevent arterial occlusion, retroperitoneal hemorrhage, and potential limb loss.
Give me the one-sentence clinical picture of a renal crisis.
You are standing over a patient with a history of decreased cardiac output who was just given a nephrotoxic medication and who suddenly develops oliguria and escalating BUN to creatinine ratio indicating poor perfusion and peaking potassium levels on their morning labs.
And the ultimate, if you see X, think Y and do Z's rule.
If you see bright red bleeding or thick clots after a cystoscopy, think bladder perforation or severe internal hemorrhage and notify the provider immediately while preparing for aggressive intravenous fluid resuscitation.
That is the intensivist mindset. You don't just react to the alarm, you anticipate the failure at the cellular level before it happens. We want to thank you, the listener, the crucial third mind in this room, for joining us on this intense deep dive into the urinary system. You are now armed with the clinical reasoning to look past the surface and truly understand why every single drop of urine matters.
It's all about connecting the underlying mechanism, the why, to the clinical reality of what you are seeing at the bedside.
Exactly. And I want to leave you with a final thought to mull over. We began by talking about the glory of the heart and the lungs. We watch the monitor for the electrical heartbeat. We stare at the chest, waiting for the rise and fall of breath to tell us if a human being is still alive. But consider the reality of what we just discussed. If the kidneys are manufacturing the exact right cocktail of hormones to sustain blood pressure, if they are retaining the precise milliequivalent of sodium required, If they're balancing the acid in your veins, they're producing exactly 1 milliliter of urine per minute out of a massive chaotic flood of blood. Maybe the truest reflection of a human being's survival isn't the loud rhythmic beating in their chest. Maybe it is the quiet, unfathomable, microscopic intelligence of their nephrons. The next time you empty a Foley catheter bag, don't just write down a number on a chart. Look at the fluid and ask yourself, what is this exact chemical composition trying to warn me about?